Very good morning to all of you. So once again, welcome to the Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a teaching class on principle of antimicrobial therapy and antibiotic prophylaxis for common urological procedures. This will be presented by Dr. Dhruvan and moderated by Dr. Manoj Bamania. So I request Dr. Dhruvan to kindly start your presentation, please.
Yes, sir. Good morning, everyone. Today I'm going to present a seminar on principle of antimicrobial therapy and antibiotic prophylaxis in common urological procedures. First of all, regarding the selection of antibiotic, antibiotic selection should be based on the many factors like the source of infection, whether infection is complicated or uncomplicated, adverse effect and efficacy of the drug, and cost of the drug. In dose and duration, the concentration of drug in blood is important in the case of febrile UTIs and the conditions with the involvement of parenchyma. In case of renal insufficiency or renal failure, where there is a dose modification required because in renal failure or some case of obstruction, there is a concentration of drug may not be adequate up to the mark which required for the action of the drug. And to prevent and decrease the resistance and the inappropriate use of antibiotic, we should initiate therapy not based only on the culture and sensitivity, but also on the clinical judgment and clinical presentation. According to some studies, urinary analgesics are also valuable to shorten the duration of therapy and reduce the symptoms. Coming to the antibiotic resistance, first of all, collateral damage. It is occur with antibiotic like bacterial resistance, or it is colonization with multi-drug resistant organism. It is mainly occur in the some cases with low risk like uncomplicated cystitis, in which there is a minimal risk of progression of disease, but problem is the patient which taking the medicines are exposed to resistance for other antibiotics. Resistance occur mainly because of the three mechanisms: intrinsic chromosomal resistance, acquired chromosomal resistance, and extra chromosomal plasmid mediated. Intrinsic chromosomal resistance is a resistance. It is occurred due to the absence of some enzymes or the mechanism on which antibiotic can act. In acquired chromosomal resistance, it is occurred during the therapy. In this resistance, after the 24 to 48 hours, resistance develop to the other organism which are resistant, and it is mainly occur when the antimicrobial level is below to the level of minimal inhibitory concentration of the drug. Factors associated with these are underdosing, non-compliance, and some diuresis can cause a decrease in concentration of drug. So antibiotics should always be prescribed with adequate dosage and duration, and it should be compliant to patient. Third one is extra chromosomal mediated resistance. It is acquired and transferable via plasmid. All the antibiotics are capable of causing this type of resistance, and it can transfer within the species and across all genus of bacteria. And resistance to one antibiotic can cause resistance to other antibiotic also. Antibiotic resistance influenced by the reduction in dose and duration of the drug, and inappropriate and excessive use of drugs. Coming to the antimicrobial formulary, it is include the mechanism of action, coverage of the antibiotic, precaution, and contraindication of the drug. It is divided into two classes: bacteriostatic and bactericidal. Bactericidal refers to the irreversible death of bacteria, whether bacteriostatic is a killing organism and it is a reversible. Quinolones, beta-lactam, vancomycin, and aminoglycosides are bactericidal drugs, whether the clindamycin, sulfonamide, tetracyclines, and chlorpheniramine are the bacteriostatic drugs. Mechanism of action: The drugs like cephalosporin, penicillin, and fosomycin and vancomycins are mainly acted by inhibition of bacterial cellular synthesis. Whether the aminoglycosides are acted by the inhibition of ribosomal protein synthesis, quinolones are acted by inhibition of bacterial DNA guidance, and nitrofurantoin is acted by the inhibition of several bacterial enzymes. Coming to the coverage of the antibiotic, antibiotic include mainly penicillin like amoxicillin or ampicillin. They have coverage for gram positive pathogen and some of the gram negative like Proteus, Klebsiella, and ampicillin is subrectum also covers the Haemophilus influenza. Anti-pseudomonas penicillin like piperacillin or tetracycline, they also cover the gram negative pathogen, even the Pseudomonas aeruginosa. Coming to the cephalosporin, the first generation cephalosporin are active mainly on the gram positive pathogen. They also covered some negative like E. coli or Klebsiella. Second generation cephalosporin like cefuroxime, cefaclor, they covered the both gram positive and gram negative organism, but not the Pseudomonas. And third generation cephalosporin, specific the ceftazidime, it also covered the Pseudomonas. And the drugs are like aminoglycosides, fluoroquinolones, and STONM. They are mainly covered the gram negative organism, and even it is including Pseudomonas. And coming to the nitrofurantoin, which is covered Staphylococcus in the gram positive, and some of the Klebsiella and Enterobacteria are also covered. And trimethoprim sulfamethoxazole also cover the gram positive and some of the gram negative organism. And vancomycin are mostly used for the methicillin resistant Staphylococcus aureus. In the adverse reaction and precaution contraindication, generally drugs with penicillin are cause hypersensitivity or some and it causes also decreased platelet aggregation. And when amoxicillin is act with clavulanic acid, it can cause GI upset like diarrhea. In the anti-pseudomonas penicillin like piperacillin, ticagrelin, they also can cause hypernatremia. So it should be used cautiously in patient with sodium sensitive to sodium loading. Nitrofurantoin, the side effects are generally it can cause the polyneuropathy or sometimes pulmonary hypersensitivity. Precautions should be taken in patients with low creatine clearance, and it should be avoided with the use with probenecid use and magnesium of quinolones, which are antagonistic effect with nitrofurantoin. Aminoglycosides, these are mainly nephrotoxic, phototoxic, and it can also cause neuromuscular blockage. So it should be avoided in myasthenia gravis, in pregnant patient and patient with impaired renal function, and other drugs, other ototoxic, nephrotoxic drugs should be avoided with aminoglycoside. Fluoroquinolones, it is a GI effect or sometimes CNS depression effect like dizziness or confusion. Fluoroquinolones should be avoided in the children or pregnant patient, and it also increases the warfarin effect, and it also interferes with the anti-diabetic drugs. Coming to the trimethoprim sulfamethoxazole, it has an adverse effect like rashes, GI upset, and it has photosensitivity. And the adverse effects are raised in the patient with AIDS and elder patient, and it also should be avoided in the pregnant patient. And it is used cautiously in a patient who taking warfarin. Cephalosporin also has hypersensitivity with GI upset, and it also causes a decrease of platelet aggregation. And it used very carefully in the patient with immediate hypersensitivity to penicillin and patient with the delayed hypersensitivity reaction. STM has not that much significant side effect. In very rare cases, it has incidence of cross reactivity in penicillin or cephalosporin allergic patient. Vancomycin has adverse effect of Redmond syndrome, which include flushing, fever, chills, and rash. And you should be used carefully in patient taking ototoxic or other nephrotoxic drugs. In pregnancy, the drugs can be used as safer are penicillin like ampicillin, amoxicillin, and drugs of the cephalosporin class is safe, and nitrofurantoin is also safe. These are the drugs should be avoided, like trimethoprim, erythromycin, fluoroquinolones, and tetracyclines. Coming to the antibiotic prophylaxis, is a treatment with the antibiotic before the procedure and after the procedure to the limited time to decrease the local and systemic post-procedural infection. It should be used in all procedure when there is a risk of breach in the tissue barrier, and urine culture is recommended before before giving the prophylaxis. Antibiotic prophylaxis generally should start within the 60 minutes of the incision, except for the vancomycin fluoroquinolones that can be given within the 120 minutes before incision. Main aim of this prophylaxis is that the minimal inhibitive concentration level of the antibiotic should be maintained in the blood throughout the procedure, and in some cases even after the procedure up to 24 hours. In some cases of documented infection or cases of foreign materials, it should be given even after 24 hours. Choice of antibiotic for prophylaxis are dependent on the patient's risk factors, allergies, and cost of antibiotic. Generally, single dose prophylactic antibiotics is enough and appropriate for the majority cases, and it should target the local organism, and dose should be modified in case of renal failure or renal insufficiency. Factors to decide given the prophylaxis, there are 5 factors. Is a patient factor and the procedure which is going to be performed, and procedural factor, virulence of bacteria, and potential morbidity of any subsequent infection. In patient factor is mainly include the age, and then the conditions that lowers the immunity, like chronic corticosteroid use, smoking, immunodeficiency, and presence of any foreign material like stents or indwelling catheter, or distal obstruction or distal coronary infection. In procedural factors, procedures are divided into 4 classes. It is clean, contaminated, and dirty wound. Clean procedures are procedures which are uninfected and there is no entry of GU or GI tract. Clean contaminated procedure are include with controlled entry into genital or GU tract or GI tract, and contaminated are the procedure that include the major spillage of GI content or break in the sterile tract. And dirty infection wound are the with pre-existing infection or perforated. Now the procedure specific recommendations. First of all is the ureteral catheterization. According to AU guidelines, prophylactic antibiotics are not indicated except in the patient with the risk factors. Risk of infection in one-time catheterization is 1 to 2% in the healthy domiciliary women. And if there is a documented infection, full course of therapy are indicated. For the transrectal ultrasound guided prostate biopsy, antibiotic prophylaxis are required, and it is recommended. Fluoroquinolones are generally given within the 1 hour of the procedure, and EA also suggests rectal cleansing with povidone iodine with the antibiotic prophylaxis. For urodynamic study and the cystoscopy without any manipulation, generally antibiotic prophylaxis is not recommended for routine cystoscopy, but it's given in the presence of risk factor like any recent instrumentation or recent use of antibiotic or neurogenic lower tract dysfunction, or in immunocompromised patient, or in patient with anatomical or function abnormality. Now coming to the TURP and TURBT, in this antibiotic prophylaxis should be given in all the cases, and preoperative culture is obtained and should be treated with at least 3 to 7 days if culture is positive, and in case of patient with indwelling catheter. And prophylaxis should be given, and for TURBT, according to EAU guidelines, if there is a large tumor present, then prophylaxis is given only. Other there is no requirement. In ESWL, it is also if there is a pre-procedural culture is positive, then it should be treated for at least 3 days. And EAU recommends only prophylaxis if only following risk factors are present, like presence of any stent or distal obstruction or stone is infected. And AU guidelines recommends prophylaxis in all the cases. In the ureteroscopy, this is the same. The prophylaxis is recommended in all the cases, and preoperatively culture should be obtained and should be treated. And procedure not performed if there is a presence of active UTI. And during the perio period, low internal pressure should be maintained to decrease the post-operative infection. On percutaneous renal surgeries, it is in these cases if pre-procedural blood culture is positive, then it should be treated for at least 7 days. Prophylaxis should be given in all the cases, and during the procedure, if purulent fluid is present during the puncture, procedure is stopped, and percutaneous nephrostomy tube is closed. And during the procedure, low internal pressure should be maintained. For open or laparoscopic surgery, if there is a clean procedure, then there is no need of antibiotic prophylaxis. In case of clean contaminated procedure, like when there is a control entry in the GI or GU present, like PUGO repair or prostatectomy or any bladder surgery, single dose of prophylactic antibiotic is required. And in some contaminated procedures like use of the large bowel or there is a gross spillage of content, then there will need of the antibiotic prophylaxis, and even after the procedure it should be given for long duration. In the dirty procedure, there is a treatment is given according to the culture and sensitivity. These are the AU guidelines for the prophylaxis for the lower unit procedure. Choice of antibiotic mainly for all of the procedure are fluoroquinolone and trimethoprim sulfamethoxazole. And alternative, we can use if there is a resistance to these drugs or an allergy, then we can use aminoglycosides and first or second generation cephalosporin. Especially in the transrectal prostatic biopsy, the choice of antibiotic are fluoroquinolone or second or third generation cephalosporin is the chance of infection are more in these cases. In upper urinary tract instrumentation, in socal lithotripsy and the ureteroscopy, the choice of antibiotic are fluoroquinolones and trimethoprim sulfamethoxazole. Whether in percutaneous surgery, the choice of antibiotic are cephalosporin first or second generation. It should be used with aminoglycosides and metronidazole. And if there is a resistance to these drugs, we can use ampicillin sulbactam or fluoroquinolones. For an vaginal surgery, there is an organism mainly of GU tract and skin. So choice of antibiotic are first and second generation cephalosporin with aminoglycoside and metronidazole. In the open surgery, when there is a no entry in GU or GI tract, it is given if only risk factors are present, and first generation cephalosporin are preferred, or alternate to this, clindamycin can be given. In the surgery with involvement of GU tract, first, second generation cephalosporin are preferred with aminoglycosides and metronidazole. And when there is an involvement of intestine is there, it is shifted to second or third generation cephalosporin. Or in alternate, we can use ampicillin sulbactam or piperacillin tazobactam or fluoroquinolones. These are the recommended dose for the prophylaxis drug, which in fluoroquinolones, the levofloxacin is 500 milligram OD, and aminoglycoside routinely use amikacin, which is 15 mg per kg. In single dose is preferred. And in cephalosporin, for first generation IV drug is cefazolin, which should be given 1 gram TDS. And the second generation cephalosporin injectable is cefoxitin, which should be used 1 to 2 gram IV 8 hourly. And in third generation cephalosporin, like ceftazidime, it is given 1 gram 12 hourly. Taxim and cefoxitin are given 1 gram 8 hourly. Amoxicillin with clavulanate, it is usual dose is 625 per orally, 8 hourly. And ampicillin sulbactam is 1.5 gram given 6 hourly. Metronidazole is dose is 500 milligram 8 hourly. And piperacillin tazobactam is also given 4.5 gram 8 hourly. And vancomycin is given 1 gram IV. And special conditions like patient with risk of endocarditis, according to American Heart Association, administration of prophylactic antibiotic is not required in the GU procedures, even in high risk patient like issue of infective endocarditis or prostatic heart valve disease. In patients with indwelling orthopedic hardware, if there is a duration of the replacement is less than 2 years, then prophylactic antibiotic is recommended. And choice of antibiotic is if I want to give orally, then it is fluoroquinolones. Or in case of IV, we can use ampicillin with the gentamicin, or substitute is the vancomycin 1. Antifungal prophylaxis. In case of asymptomatic funguria, if procedure is minor like union catheter exchange or stent placement, then there is no need of antifungal prophylaxis. But in case of endoscopic or open robotic surgery, single dose of antifungal prophylaxis are given. If want to give oral, tablet fluconazole is given, and in case IV dose, we have to give amphotericin. And for any symptomatic fungal UTI, antifungal therapy is given for the whole period rather than single dose. These are the EU guidelines recent for the uncomplicated cystitis. In the first line therapy in the women, generally for single dose of fosfomycin is also preferred, and except these NITROFURANTOIN microcrystal 100 milligram BID or NITROFURANTOIN monohydrate 100 milligram BID given for 5 days, and P-mesalenum 400 TID also can be given for 3 to 5 days. And in alternative, we can use cephalosporin for 3 days. And if there is a resistant localization for E. coli less than 20%, then we can use trimethoprim sulfamethoxazole 960 milligram dose for given for 3 days. And in men with cystitis, trimethoprim sulfamethoxazole are preferred. It is given for 7 days. In case of uncomplicated pyelonephritis, the first line treatments are fluoroquinolones and cephalosporin, third generation cephalosporin like cefotaxime and ceftriaxone. And if it is not ruled, then second line treatment is fourth generation cephalosporin like cefepime or aminoglycoside like gentamicin, and piperacillin tazobactam can be given. And last line treatment for the pyelonephritis are the imipenem with cilastatin and meropenem or ceftazidime avibactam can be given. And complicated UTI recommendations are to use the combined drugs like amoxicillin with aminoglycosides and second generation cephalosporin with aminoglycoside, or we can use third generation cephalosporin as an empirical treatment. Ciprofloxacin used only when there is a resistance less than 10%, and when patients are taking the treatment is given orally, and patient has a reaction anaphylaxis according against the beta-lactam antimicrobials. And it should not be, fluoroquinolone should not be used in a patient with complicated UTI and patients who have used fluoroquinolones in the last 6 months. For the urosepsis, the suggested drugs are third generation or fourth generation cephalosporin and piperacillin tazobactam or ceftazidime avibactam, and aminoglycosides, gentamicin, amikacin, or in some cases meropenem or imipenem with cystatin can be given, and it is given generally for 7 to 10 days. In case of chronic bacterial prostatitis, fluoroquinolones are given orally. It should be given 4 to 6 weeks. And in case of chlamydia trachomatis, we can use the doxycycline or azithromycin. Doxycycline given for 10 days. And metronidazole is given 500 milligram TDS for 14 days in case of trichomonas vaginalis.
Hello. Thank you. Thank you, Dhruven. And if anybody has any other query, suggestion, idea, please let me know. So we all know that antibiotic prophylaxis and use of antibiotics is a very important topic, because most of the times we neglect this chapter, and we know that use of antibiotics, which has become often very improper misuse, which has resulted in so much of resistance. And it has been seen that in the near future, if this antibiotic resistance continues, then probably we may have no antibiotics even for very minor kind of infections. So it is very important that we use antibiotics in a proper manner. And most of the good institutes, they do have an antibiotic policy also, which is very important in every hospital. So I would request Dr. Manoj, if you have any comments to make, please go ahead. And the residents, and if any faculty member who might have joined us today from outside, if they have any comment to make, please go ahead.
Sir, some comments from Nachiket sir.
Yeah.
Yes, Dr. Nachiket, go ahead.
So no comments. I just wanted to ask him. Cephalosporin seem to be the mainstay of treatment of these UTIs and all, right? So according to you, inside our department, which is the generation of cephalosporin which works, and what are the different cephalosporins that you use in the department?
So we generally use third generation
cephalosporin.
So the ceftazidime or ceftriaxone.
Ceftriaxone is third generation cephalosporin. How many generations of cephalosporin do you know? Because there's a classification. Cephalosporin is a very broad spectrum. It's a huge family. So how many generations of cephalosporins do you think that you've studied or do you know?
So five generations.
There are 5 generations. So are you sure that ceftriaxone is of the third generation? Dekho bhai, ceftriaxone, third generation. So what about the resistance of ceftriaxone? Do you think that the resistance pattern is in favor of ceftriaxone in our department? Ceftriaxone se kitna resistance do you see?
In many patients.
Many patients.
I
mean, majority of patients would have resistance to ceftriaxone according to me. So I think that is still mainstay to apne hospital infections mein now. Piperacillin tazobactam seems to be working right now, and I think that the higher generation, 4th generation, I think that meropenem seems to be working now, and ceftriaxone still there's a lot of resistance, and but we have to be careful. And I don't have any comment because I've not read much on the subject, but I think that piperacillin and meropenem, they are our mainstay. So we cannot follow what the Americans are saying, that for a first dose give ciprofloxacin, only a single dose of ciprofloxacin or trimethoprim will work. It is not going to work inside our setting. And so I think that the very basic antibiotic which we have is aminoglycosides. They seem to work. Resistance is not known in aminoglycosides. As a matter of fact, it's very peculiar for aminoglycosides to show any kind of resistance. And I think that on account of the plasmid factor has not been found for aminoglycoside resistance. The plasmid factor are. So I think that we should not be swayed away by what you're telling us, that trimethoprim is enough for a prostate biopsy or sulfamethoxam is enough for a cystoscopy or a DUR. It's not that way, because we have a lot of bug resistance inside our setting. So, but that is the only thing that I want to say. So, I think that we need to have presentations which are not skewed by American data, because he already has given all guidelines based upon AUA, and I don't think that that would hold any water inside, because we have a lot of resistance. So it's good to write in an exam, but practically I don't think that it's that way. Like you said, even in simple cystitis, it's complicated. So this is the only
you are right, Nachiket, because when you talk about antibiotic resistance, it is very important to know the antibiogram of a particular area where you are giving these antibiotics. That is why antibiotic policy is so important. So even different ICUs, different wards of the same hospital may have a different kind of resistance. So it is important to know the antibiogram of the particular ICU or the ward where you are treating these patients. That's why I always insist upon to get an antibiogram from the pathology microbiology lab, so that we know exactly which antibiotics are working at present in your particular setting. And definitely what is in United States or other parts of the country may not be true for our own setting. So again, this not only varies from country to country, but it varies from hospital to hospital also. So I think that is very important. Anybody has anything else to say? If not, then I would ask Dr. Manoj to please wind up and close the session.
Thank you, sir. Very good discussion about the resistance and the prophylaxis of the treatment. Thank you, all of you. Good day.
Thank you. Thank you. Have a good day, everybody. Thank you.